Anaphylaxis is a life-threatening condition as bronchial constriction can lead to airway obstruction and vascular collapse. Death can occur within minutes to hours after initial symptoms. Also, severe cases can result in hypovolemic shock. Poor prognosis risk factors include use of beta blockers, those who have asthma, and the elderly population. Anaphylaxis falls under the type 1 hypersensitivity reaction, which involves IgE antibodies. The IgE antibodies attach to mast cells and basophils, which then release inflammatory mediators such as histamine, leukotrienes, and prostaglandins. For more details regarding the pathophysiology of anaphylaxis, watch this video on hypersensitivity reactions. Anaphylaxis starts suddenly within seconds to minutes of exposure to a substance that produces an extreme allergic response. Some of these offending substances include food allergies, such as nuts, eggs, shellfish, antibiotics such as penicillin, vaccine preservatives found in MMR and IPV, for example, latex, and insect venom. Clinical manifestations can be systemic or local. Initial symptoms are typically edema and itching at the exposure site. Other symptoms include hoarseness, wheezing, flushed appearance, patient complaining of a lump in the throat, or chest tightness, upper or lower airway obstruction. Cutaneous wheals with erythematous raised borders and blanched centers can also develop. They can be localized or generalized and may coalesce to form large hives. Angioedema may also be present, which is a deeper, non-pitting edematous process. Patients may complain of a burning or stinging sensation from this. If angioedema manifests in the bowel wall, it can lead to shock and vascular collapse. If you are finding value in this video, then please hit the thumbs up and subscribe. Shock can occur rapidly. Signs of this include tachycardia, hypotension, dilated pupils, dyspnea, and cyanosis. Death will occur if emergency treatment is not initiated immediately. Anaphylaxis requires immediate medical and nursing interventions. The primary basis of management is speed in these tasks: recognition of signs and symptoms of anaphylactic reaction, assessment of respiratory status and maintenance of patent airway, drug therapy administration and treatment for shock, and prevention of allergen spread by using a tourniquet in the case of injected allergens. Initial interventions include calling the healthcare provider and rapid response team, ensuring patent airway, administering high-flow oxygen with a non-rebreather mask, removal of insect stinger without compression if present. A cornerstone of treatment for anaphylactic shock is rapid infusion of fluids. You will need to establish IV access for infusion of normal saline. Intramuscular injection of epinephrine and administration of nebulized albuterol, Benadryl, and corticosteroids are also important interventions. If the patient becomes hypotensive, then you want to consider the following actions. Place the patient in a recumbent position and elevate their lower extremities. Increase and maintain blood pressure with fluids, volume expanders, and vasopressors. And administer IV epinephrine as prescribed, typically around every 2 to 5 minutes. Patients receiving beta blockers might be resistant to epinephrine treatment and can develop refractory hypotension and bradycardia. Ongoing monitoring actions include assessing the patient's vital signs, respiratory effort, level of consciousness, and cardiac rhythm. If the patient experiences severe respiratory distress or severe laryngeal edema, then expect intubation or tracheostomy to be performed. You will want to document the anaphylactic event, interventions, and patient response. Also list all allergies in the patient's medical record and nursing care plan. Thank you for watching. Check out the link in the description to buy an instant digital download of Anaphylaxis nursing notes. Have a fantastic day.